Oh, I got a gavel in front of me. Good morning or good afternoon, everyone. What time of day it is? It's been a long, long day. Okay, so we are going to get started with our HB 3610 Task Force on Alcohol Pricing and Addiction Services. Adam, can you call the roll, please?
Senator Sullivan,
Present by video.
Senator Canope, Chair Sanchez,
Present.
Senator Reschke,
Excused.
Chief Doug Barrett,
Present by phone.
Vaughn Berry,
She's coming. I talked to her, but maybe slightly delayed. So.
Maybe coming in a bit late. Oh, shoot. Sorry, folks. There we go. Right button.
Rob Corbett, Annalise Dolph,
Present.
Jamie Floyd,
Present.
Dr. Tom Jean,
Present.
Todd Jeter, Homer, Sarah Lochner,
Present.
Jana McCamey,
Present.
Director Prince,
Present.
Marcus Reed,
Present.
Jason Renaud,
You got it?
Janelle Romaine,
Here.
Lara Salazar,
Present.
Aaron Sarnoff Wood.
Present.
Quorum is present.
Thank you. Perfect. Okay, folks. So, much as we sat around here and chatted for a little bit, I still didn't get my business together here. So here we go. We did the roll call. Discussion of the 2024 work plan. I do want to note that we may have a few changes to the which is the 13. Okay, sorry. The date.
It's a
July
June 13th.
June 13th. I just wanted to make sure.
Yes.
It's like the June 13th. We wanted to have a couple of folks come in and talk about sort of the benefits and drawbacks because of course, the AOC is also they don't have a huge presentation. So we have a little bit of time on there. So we wanted to talk about the benefits and drawbacks of imposing taxes on malt beverages and wine. So just, I think it's important to have the conversation, both ends of it. So we will be looking at the possibility of that, and we can discuss a little bit more about it later, but just wanted to put that out there for you just in terms of that. That's our discussion piece on the work plan. Any feedback from members on that?
Is that an additional day or just as
No.
part of the June 13th meeting?
Part of the
Okay.
June 13th
Got it.
meeting, yeah.
Okay.
So, yeah, we haven't set up any additional days other than what's on the work plan right this very minute. So, okay, and then let's see, let's just get moving then. I'm sure you have all received the substance use disorder financial analysis report that's been posted on the OHA website. You have it clickable on your little notes there if you're looking online. So let's just get moving here. Samantha Byers and Samantha DuPont, the Sams, please come up and take a seat. And so I love it that we're in this place and you can actually jump up in here and do the thing. So feel free to introduce yourselves however you're going to start.
Thanks for the opportunity to be here. You get two Samanthas today.
Perfect.
much more helpful. So I'm Samantha Byers, Adult Behavioral Health Director at OHA. And I'm going to introduce yourself.
Yep, Samantha DuPont. I'm a behavioral health structures analyst. I'm also the incoming program administrator for our certified community behavioral health clinics program.
So today we're giving an overview of the study and going over a few details around expenditures. I know that I was before you when we had just the draft and there were some questions. We returned answers, and then here we are with the final product. Hard to believe, and here to present some of that to you. So for today, our overview will just be a little bit about the study background, the financial inventory, the cost estimates to address unmet need, and then revenue sources to meet the need, and then key takeaways and next steps. One thing that I will say about this study is as you delve into it a little bit more, and even as we were making sense of it and trying to package it together in a, not just the report, but in a presentation, the blending and braiding of funds makes the SUD service delivery system very complex in terms of sussing out the dollars. So our hope is that not only will you understand a little bit more, but that you'll have more questions as well and be like, hey, I would love to kind of get more detail on this particular line of revenue. So that's really the intent. The study background, I think some of you know, came out of a 2021 session, really asking the agency to conduct a study that looked at the funding sources for the substance use disorder continuum of care throughout all agencies, so not just OHA. And then really to analyze the cost requirements to meet unmet needs and provide additional revenue sources. The goal was to really understand how to maximize funding to make service delivery efficient and effective and equitable, to have an idea of what it would cost to fill in all the unmet needs, and then also just to see how public dollars are utilized to support the continuum of care as it relates to substance use disorder. Then oh, good. It's behind me. I was like, everyone's looking up. I hope that's where the answer is. Yeah. So next slide. I don't know who. And one more. And one more. Thank you. So the first slide is really just showing you kind of the larger overview, and it will come as no surprise that over half of the expenditures are coming from Medicaid, spending on Medicaid reimbursable services, and you'll see this again, but this is the overview that we'll go through with you in more detail today. The next slide is really showing that over half of substance use disorder expenditures are supported with federal funds. For us, that is not a surprise, but it's just kind of good to know that a lot of our braiding includes quite a bit of federal government dollars. And just a quick note in terms of the block grant, it used to be called the SAP block grant dollars, but they've changed the name, the acronym. The 53 million for this particular biennium is higher than it normally is for the block grant because we had the COVID and ARPA dollars that came through. So that was just in this snapshot, you're seeing that, but also keeping in mind that that would not be a normal amount. And then this also these funding sources are around funds that are going to the state and having the state distribute out. So they're not reflective of funds going directly to cities or counties that are not being delivered by the state. So also to note there.
Sam, excuse me, can you tell me what an average might have been for the block grant rather than what the bump has been? Do we know?
The number figured here is inclusive of about 13.8 million in supplemental funds during COVID. And just to reiterate one of the points, the spending figures you see here, it reflects what left the state coffers. It doesn't reflect what was allocated or budgeted. It reflects what was actually paid out during the 21-23 biennium. Yeah. So this is where a lot of questions come up where folks say, oh, I thought we gave much more than that, but the approach that the consultant used was looking at the lowest common denominator across all budget data that they had received, and that expenditures that left the state was that lowest common denominator.
Thank you.
Next slide. So this is just looking at the spending across the care continuum and percentage of funds spent. And you can see that not as much on prevention. And I actually think less on harm reduction than we talk about harm reduction, which is kind of interesting at 3%. The bulk of the money going to treatment. We see 10% going to peer delivered services, and programmatically speaking, really see that as an intentional spend that included policy and decision making around recovery supports, and that being a critical element. And then you see some general recovery supports and drug courts. So that's just allowing you to see the continuum and where the spendings go. Next slide. No surprise, spending by county, you can see that kind of our I-5 corridor meet the top 5 in terms of expenditures, with Multnomah County having the majority. That, I think this is just to show you most of the dollars flowing into urban counties, and Multnomah County in particular is outpacing the rest of the state. So I think anything more you want to say on that?
Yeah, I think what's important to note about this spending by county, first of all, again, it's distributions out of the state coffer. So this is not telling you what a county might spend out of their own funds. It's based on zip code data, from contracts, from Medicaid claims encounter data, where the dollars are going. And that's an important point, because what it's really showing you is where the resources are located, where the providers and organizations delivering SUD services and supports are located.
So another quick question on that one. Is there a place where we can see that state contribution, that county contribution, and the other contributions that might, just so that we can see the numbers in a much more
In terms
way?
of counties and how they spend their own funds. So there was some attempt to do that in this report. Unfortunately, the consultant didn't have a lot of deep analysis on it, partially because of data sufficiency. But we do have, as a supplement, as part of our state data gathering, we did get city and county distribution. So this was what was directly given to cities and counties for marijuana and alcohol. So we do have those as supplemental documents if this task force is interested in seeing it. And just as a quick top line for that amount, I don't know if do you want to go back to the funding sources slide? Because we did.
The one more, I think.
I think it's
There it
yeah.
is, yep.
So one thing you'll notice here that's not, this was pulled out of the report, a couple different data points, is some additional information on expenditures from marijuana revenue, tobacco, and alcohol. The marijuana is obviously very high, $221 million expended from the state, and that is mostly due to the Measure 110 funds. So those funds originally were getting more directly distributed. They then got rolled into a sort of a state account, and we can get into the details a little bit more about Measure 110 later. Next on there, you'll see, based on what comes into the state, what comes into state agencies, 42 million of tobacco revenue, and then about 13 million from alcohol revenue. Again, we can provide the direct distributions for both marijuana and alcohol separately.
So, hold, Senator Solomon has a question.
Thank you so much, Chair. Appreciate it. I had 2 questions. One quickly, is there a universal definition for harm reduction?
That's an excellent question. So I think that harm reduction, just programmatically speaking, is a strategy that works across the continuum, as opposed to syringe exchange, which is part of harm reduction, but isn't necessarily the definition of it, right? So harm reduction is really trying to reduce harm, as it sounds, at any point in the continuum, and just show improvement and continue lives, right? That's really the piece of it. So we do harm reduction, obviously, in terms of overdose reversal, reduction in the spread of infectious disease, but also within within treatment, we do harm reduction. So for example, methadone was one of the original harm reduction tools. So medication assisted treatment would be on that continuum. Contingency management is part of that in some places. So there's a universal definition probably around the concept of it as a strategy, but not necessarily like these are the core elements that make up harm reduction programming, though we do categorize those upfront pieces like syringe exchanges and overdose reversal and MAT as part of harm reduction. I
Thank
don't know
you.
if that helped answer the question a little bit.
Follow-up, Chair?
Yes.
Thank you. Thank you so much. And I think it would be helpful too, is if that was further broken down when you have that on a percentage on the slide to say, this is what we mean by, because that terminology really is unclear to a lot of people because it means very different things to a lot of different people. My next question is another fun doozy. Is there dollars? So do you have anything that talks about dollars to measurable results? I mean, we see Multnomah County receiving this bulk of the dollars. Is there anything to say that what Multnomah County is doing, is turning the tide, is actually with those investments? Or, yeah.
I would say that there's outcomes data out there, but the main challenge is that it's not standardized. So much money, especially within the behavioral health division, all of our money goes out into grants to individual organizations, and they can all have different reporting requirements, financial reporting requirements. And so this is the struggle, is that it's not that we don't know, it's that we have a very hard time aggregating it at the moment. And this isn't just within OHA, it's across all state agencies that we've seen.
I would also add that I think that a lot of our funding sources, and this is true in particular on federal grants, are very specific to either a specific program or a specific population. And so when we think about outcomes in terms of the health of a county or the health of the state as it relates to substance use disorder, that also tangles it a little bit because, as Sam said, everything is so unique depending on the federal requirements. Having said that, I think both our counties and OHA is really interested in refining and coming out with specific outcomes that show success in the health of, all populations in an equitable fashion. So that is really the phase that we're in terms of like what are the universals, right, that we can look at? And then, how do we make it not as burdensome as some reporting has been in the past, understanding that there are grants and other requirements that we sometimes don't have any control over in terms of reporting and administrative needs.
Okay. We have a lot of questions coming up, and I really want to make sure that you all have some time to finish, to go through your slides. So I'm okay with answering a few short questions if we can say that. And then also remembering that we have the Association of Oregon Counties coming next time, who may be able to answer some of these questions as well when they run specific to counties. Okay, so Sarah.
Hi, everyone. Sarah Lochner, Coalition of Local Health Officials for those online. Similar to Senator Solomon's question, could you define prevention for us in terms of how you defined it in these slides? Because I think prevention is horribly underfunded in Oregon, and I was surprised by the 6% number. So I think my definition might be different than your definition.
So the consultant worked with the public health division to look at, this is where my acronyms, I'm not going to be able to unpack them, essentially coming from the CDC, I believe, right, Tatiana? He's up.
Tatiana, please come up and, yes, if you would please, and introduce yourself. And
Hi, I'm joining my
joined us.
team over here. I'm Tatiana Deerwichter, the Substance Use Primary Prevention Manager. And so the steering committee that supported the work over the year, along with our tribal partners, agreed to use SAMHSA's definition of primary prevention, which includes 6 different strategies, which I believe are highlighted in the report and will show up in one of the slides. So, but primary as in preventing before it starts.
Perfect. Thank you.
thank you so much, Erin.
Yeah, you mentioned outcomes data was difficult. Do you have any metrics on increased access to services? I mean, better accessibility, more people able to obtain the services they're looking for?
Yeah, so I think that it's interesting that you asked that. We've been looking at that as it specifically pertains to the Measure 110 funds, so the marijuana dollars in particular. And we have not totally kind of scrubbed the data, but as we're looking at claims data and other sources from providers, we are seeing a pretty significant increase from 2021 to 2023 in access. So people entering treatment service and getting some level of service, whether it be an assessment or, you know, ongoing care there. So we are seeing that, but that piece is something that we are starting to measure more and started with 110 just to see what it looked like and how we can tap into it.
Just to add on to that, you'll see some graphics later on in the presentation that illustrate the blending and braiding of funding sources. And I think one really important thing to take away from that is that we absolutely want to track outcomes. And when you have 8 different funding sources going into something, it can be very hard to say which dollar and which part of that funding source really got to that outcome. So not to make it a futile exercise, but it does become very complicated when you blend and braid. Measure 110 is nice because it has one funding source. And so when we're tracking the impact of those dollars is a bit more straightforward.
And even that gets a little tricky because you cannot supplant, right, with $110. So even figuring out like the half 0.5 FT of the certified clinician was paid for by some grant and the other half was paid by 110. So it's tricky. But that doesn't mean that the overall health and population health is something that we can't look at to say all of these fundings going in are producing a better outcome for the state's health, for sure.
Thank you.
I think my question might be a little bit longer, so I don't know if we have time for it, but mine was also about outcomes. How do you make decisions on the front end when you have this pot of money, you're trying to decide which programs it goes to, and you don't have information on outcomes about the program? How are you making those upfront decisions about who qualifies for the money?
So that's a really good question. I think that's the interest in outcomes. So there's a couple things. Our community mental health programs are our safety net, right? So they're kind of an extension of OHA. They're funded specifically to do a lot of our mental health work and crisis work, but also some of our SUD work. So that piece is something that we work on and refine and with Cheryl, with AOCMHP often and meet with them regularly. The other piece is that there are reports that providers turn in to demonstrate that they are utilizing the funds, that they are seeing people, that there are assessments done, that people have entered treatment, that they're receiving the care they need. And we know that in many of the areas of in Oregon, there isn't enough treatment. So it's a balance, and we're trying to shift some funding in order to make the distribution equitable, right? So we've had a lot of culturally specific programs that have not necessarily been funded that are now forming their own burn, and we're really trying to support that to tap into communities that have gone unserved for a very long time. So I think that part of this report, what's so interesting, I think at the beginning we thought, okay, we're going to see the funding and then be able to make really good decisions about how to distribute it and all of that. And then you look at the braiding and then you start looking at priority populations and populations that have been underserved. Thinking about the Black community sees overdose rates at a higher 2.5 times higher than other communities. It's like, then how do you balance it? And I think that's something that this report is part of our jumping off point. And I think some of the 110 funding is also where we're looking at it as well to hone in on that.
Thank you. And I want to remind folks to state your name because I think the folks online still can't see all of us. We don't have name tags in front of our name. So if you'll state your name for the record or for them to be able to hear you.
Thank you, Chair. Fawn Berry with the Oregon Wine Council. I'm just wondering if you can help me understand the state funds, what portion of those might be matched? And then with the federal funds that it shows the Medicaid match, is that money that's running through CCOs or what? How does that all work?
Yeah, so on the state side, when we're talking about Medicaid dollars going out, there's about a little bit less than 90 million of general fund that goes towards Medicaid, and then 472 million coming in from the state government, or from the federal government, excuse me. Yeah.
So the rest of that money is going to sources where there's not a federal match tied to it then?
In the state funding category, yeah. So we condensed the state fund slide for you here, really just to pull out some of the revenue from consumption of substances, but there's a much more detailed table in the report that breaks down the state funds.
Thank you.
Okay, no more questions for the moment. Let's get through some of your slides.
It's just respecting time. I think it could be helpful. We can go through the next slide, one more slide, and another slide. And I think, you know, the underscoring around the percent of Medicaid expenditures is right here, but I'm wondering if we want to get into the details more, just so that you can really get to the pieces that you're asking. So let's see.
Yeah, so we have some slides here to get a little bit more in the details on the OHA budget. Starting here with Medicaid, 562 million overall expended in the 21-23 biennium, and 90% of that goes to coordinated care organizations. And that's through capitated payments, which is a per member per month payment. The remainder of the expenditures, about 10%, is going to go towards direct fee-for-service payments to providers. Next slide. So as we just touched on, Medicaid is very heavily subsidized by the federal government, 84% through the federal match and 16% through the state match. It's important really because that federal match is the largest revenue source for SUD we have by far in the state, and that'll come up later. Next slide. In terms of the spending on Medicaid, this is based on encounter data through what's called our MMIS system. The vast majority of Medicaid, perhaps not surprisingly, goes to treatment, with outpatient coming in at the top and withdrawal management and residential treatment about 20% each. Peer services and supported employment, some of those recovery ends of the spectrum, are much less. We did want to make a note that the data that this is based on is not necessarily inclusive of all the money that's going out the door. So there's one specific thing called subcapitation that CCOs will do, and that will result sometimes in a $0 claim in our system. So some of the spending could look off, depending on if you accounted for those $0 or not. And it's also important to note that CCOs operate on a global budget. So what we pay out, what we anticipate is going to go towards SUD, might change year to year based on the real needs they're seeing in their populations. What you also won't see in the MMIS data is money that they might be investing in things like naloxone supplies. There's some CCOs that will do some of those other types of investments that support recovery and support other parts of the care continuum that may not necessarily be reflected in an actual claim. So we just wanted to make a few notes on that.
So any pilot projects that our CCOs do won't be there in this number either.
Okay.
So moving along, the next slide is new data that we pulled for this task force. So we did get a very detailed breakdown of the Medicaid encounter data. And our Health Policy and Analytics Division did look at the breakout with alcohol use disorder as the primary diagnosis to see how is the funding kind of shaking out there. The things highlighted on this slide, really the first thing that jumps out is that the majority really of the spending on the most intense side of withdrawal management, this is hospital-based withdrawal management, medically managed, is accounted for folks with AUD. It makes sense, you know, alcohol withdrawal is very medically complex, it's dangerous, and so it makes sense to see a lot of the cost showing up there. Another thing that jumps out at this data is on the residential and outpatient treatment side. If you look all the way to the last column, we're seeing lower per capita costs there for AUD versus total per capita costs across the whole data set. This is one of those things that probably raises more questions than answers. It could be that folks are getting less complex treatment. If it's residential, maybe they're not staying as long, but It's something for further investigation. But the thing that really jumped out about this data to us was that medicated assisted treatment, that red line there. When you look at the percent of total served, the percent of folks total served who had a primary diagnosis of alcohol use disorder was only 2.2% of that whole spending. So what that's saying is not many people with alcohol use disorder are getting MAT. We know that MAT uptake is low overall, but this is very, very, very low. I believe that's the last on Medicaid. I could pause there for Medicaid questions before we move on.
Aaron Sarnoff with Two Towns Cider House. You mentioned roughly, it looks like about 85% of Medicaid covered by federal dollars. Does that scale if we see an increase in Medicaid spending, i.e. basically we've heard from some of our recovery providers that the low reimbursement rate of OHP Medicaid was one of the reasons they were rationing available beds to potential patients. And if increasing that cost or increasing that reimbursement rate, 85% of that's covered by the Fed, that's proportionately less expensive to the state, possibly. So I was just trying to confirm, does those federal dollars scale with reimbursement increase?
I'm going to set aside the reimbursement increase, but just to make a note on the federal and state match, it can vary. 84 is the average across everything, but the matches can vary. I don't know if you want to speak to the rate.
I know that we've worked on a rate increase for residential facilities, and I think that my pause in just trying to think about the question was that the way the SUD system currently works and has for a long time is that if a bed is empty, it's a loss to the agency, right? So you can't actually afford to not have the beds filled in order to maintain your bottom line. So I think that was just my confusion. Like
Think that
when
they were
COVID
holding
hit, we
beds.
actually had to supplement their bed loss, right? Because we had to cut the number of beds in half for spacing. And so there were federal dollars to help supplement that.
My statement, I believe they were holding those beds for private insurance carriers because the reimbursement rate was higher. And so potentially not seeing OHP patients in favor of private insurance.
To look into that, yeah.
Okay.
Yeah.
Craig Prince, OLCC. The MAT number it jumps out to me too, and I'm not very, so this is a real question, not a gotcha question. Is that MAT for, even though it's under alcohol use disorder, is that MAT for a opioid disorder, or is that a true alcohol?
So the MAT
MAT.
category within the entire data set is for medicated assisted treatment for all disorders. And really it's a lot of it is buprenorphine for
Okay,
opioids. But this MAT, the alcohol specific data does include a few other medications that are typically used for alcohol use disorder.
Okay.
And another data point to give this some color, when we looked at the actual number of folks over 2 years in this encounter data who received MAT with primary diagnosis of AUD, 294 people.
And follow up, I'm sure. So friends that I have that have gotten into a private inpatient, they're paying for that themselves, I assume, if they have some kind of treatment in the MAT treatment in that for alcohol use disorder. It wouldn't show up in this. This is publicly funded.
This is just Medicaid encounter data. That's correct. Yeah, this kind of analysis can be expanded to look at all payer, all claims data, which would include private insurance and Medicare, Medicaid. What doesn't get captured in any of the state level data is private pay. So that's a big gap in our understanding of total state spending.
Thank you.
So Laura.
I just want to point out too that we actually can't get the MAT services that our clients need if they're on Medicaid. So Vivitrol we're able to get for our folks with private insurance, but the CCOs that we work with in Oregon were not able to get that medication without paying for it and then trying to get reimbursed, which is, $1,700 per shot, which is, too much for small agencies to cover. So that's could be another possible reason, is that those aren't available to Medicaid folks.
Okay, thanks. Oh,
Fonberry again. I'm always excited when we can figure out a way to get more federal match. And I'm just curious, have you done work to try to determine if there are pots of money that are going out that are not being matched currently, and if there's a mechanism to try to enhance that match?
So the only thing that I can say is that when we're implementing a program of any kind, even like 110 crisis system, our Medicaid team is always a part of it. And so those SMEs and specialists identify like, hey, this can bring in a match. And there are some sort of tasks and buckets that we have to look at in terms of the services. So I think that's always happening, whether or not it's 100% and there are other areas to look at. I don't know, but I do know part of our just internal mechanism is that Medicaid is always looking at the new programs. And even when we're doing policy option packages, you're having that conversation with fiscal right away. So yeah.
Well, follow up quickly. So the counties a lot of times are working with their CCO partners, but I know that there's a lot of money going out directly to counties. And I'm just curious if we've ever taken a look at whether or not there's a way to modify how that formula works so that you're matching that money before it's going out, or it's going out in a different manner, just in terms of if it goes through Medicaid, obviously it gets the match. If it goes directly to the county, it doesn't, but could be used for similar type services.
I think one of the general takeaways of this report that you'll see later on is that the more we can leverage that federal match and have things covered under Medicaid, the better for,
Right.
The state budget, and the more we can alleviate some of those budget holes. So, and there has been a lot of movement on that with the 1115 waiver recently, trying to get housing and food and some of those health related social needs rolled into our Medicaid plan. And anything we can do to continue that, route, I think would be helpful.
yeah.
If we have that as an exercise, last winter, we also submitted all of our funding for tobacco prevention and cessation as a potential match for Medicaid, as an exercise to show what would it look like if we matched our prevention funding? Would that be a way to tell the story about how that is also leading towards better outcomes? And I don't know if we've gotten the official response from CMS yet, but it was an exercise that we wanted to explore. I think to your point, like how can we be creative and looking at all sources as potential match for Medicaid?
Jana McCamey, I'm with the Oregon Wine Growers Association, just kind of on that vein. Is there a way, that we can work together, different groups, to kind of increase that pool of funding available, at the federal level? We haven't reached out to to the congressional delegation about this, but if there's a way for us to kind of work together to come up with some additional asks, from at the federal level, I think that's something that, our group could be interested in supporting as well. I'm sure there's a lot of asks, but, thinking creatively about how we work with our folks back in DC.
Yeah, absolutely. And I think, again, later on in the report, when we're talking about some of these pernicious issues like workforce gaps, that the entire nation struggles with that. Every sector struggles with that. And when I think about what are the approaches we need to take to tackle that, it has to have a federal element. It's not, any one state alone can't handle it. So I think that component you're touching on of federal advocacy and working with partners, I've encouraged, I guess.
Thank you. Apparently Rob Corbett is trying to get a hand up somewhere. Rob?
Can let it in, but I have to exit okay?
Yes. Okay. Okay, can you turn on your mic though, Rob? Not able to see me either. So.
I also think while we're waiting for the PowerPoint, one piece about the study, at least on the program side, is that the need for more funding and there are gaps, and we're seeing, for me, the MAT piece is a lot about we haven't done like a pretty aggressive strategy around alcohol, and that's something that we're developing, right? I mean, we've been so focused, right, so on fentanyl that's killing people on the spot versus something that might have a longer term fatality rate. But the other part of this report is if more money doesn't happen today, then how do we maximize the dollars that we're seeing that are going out? And I think we haven't gotten there, and that's the drill down of this report that we don't fully have, but I think there are places in the report to say, can we look at this particular line of funding? Can we look at that particular line of funding? So the report does two things. It's like, A, how can we look at funding like with matches? Like, can you kind of package something up to improve it? B, where do we need more funding? And then also C, with the funding we have, are we maximizing it? Which was the original ask of the study. Like, in terms of what we do have, is it really maximizing what we need? Is there any duplicates or anything that we can really streamline? And then from that, where else can we invest where we have it? So I think all of that is still, the report doesn't really serve that up as neatly as I think we imagined a couple of years ago, but it definitely asks the questions for sure.
Great, thank you.
Chair.
I'm sorry.
I was just going to say, I mean, I think that the fact that we have a funding formula that distributes money directly to the counties and the cities, I would assume that creates challenges with match. And I don't know if there's a way to do any kind of an analysis about, the portion of the money that's going to a county and whether or not there's a way to do something creative to guide that toward Medicaid and doing expenditures through that mechanism.
I think that's a very complicated question.
Yes.
To be honest, and I will tell you one of the things that I actually know personally is there are a lot of programs out there that don't want to go to that level because of how complicated it is. How difficult it is to actually try to get it, put resources in and get a federal match. To get a federal reimbursement for the work that they do is hugely difficult.
And I'm thinking about the state money that goes out to the counties and
Right.
kind of the ability to match that if it goes through Medicaid as opposed to going directly to counties on a distribution basis.
I think it's actually, again, kind of complicated, at least as far as I understand it. It's very complicated in terms of an actual service delivered. Not necessarily the distribution model, but the service delivered and how that gets reimbursed. Yes,
And I would add, not all,
your name.
sorry, Sarah Lochner, Coalition of Local Health Officials. Not all of these behavioral health services are Medicaid reimbursable. That is why general fund is invested and has been invested over the last 10 years, is because Medicaid doesn't cover everything, nor does it cover everyone. So.
Rob, did you have a question? You did not. You just wanted to be able to get in. Fabulous. Thank you. Okay, can we get the slides back up, Adam, please?
Having some technical difficulties back here,
Oh,
we've
no.
been disconnected. So if we could go on a brief.
Recess, pause. Just a brief one, yes.
Okay, thank you.
Hang in there, people. Technicalities. Crazy. Okay, folks, we are back and we have the slides up. Yay. Let's roll through. Are we ready for the next slide? There you go. Carry on, Lee.
So it's a great segue, actually, talking about non-Medicaid services, because that really is what the Behavioral Health Division budget is all about. We're presenting here some details on really three major buckets of expenditures. The first is expenditures through the community mental health programs. The second is the behavioral health resource networks. That's the Measure 110 funding. And then some of our other major direct grants and contracts to organizations. Next slide. So for those who aren't familiar with community mental health programs, they are our behavioral health safety net in Oregon, operating in all 36 counties. How the state distributes money to CMHPs is through a county financial assistance agreement. It's a 2-year contract, and we do funding for what are called service elements. The county financial assistance agreements and the money that comes through there is not the only revenue source for CMHPs. They do have billable services, so they bill Medicaid, they bill other insurers to the extent that they have other insured clients, and the CFAA money coming from the state is making that budget whole. That's part of what's making their budget whole for things that are not billable. Next slide. So in terms of the breakdown of the CMHP spending, you'll see here that the community outpatient SUD services is the lion's share of the spending at 37 million, with about 16 million in SUD residential. One thing that's important to note on this slide is that there are a lot of federal funds that support the CMHPs as well. About 40% of all the expenditures came from federal sources, and most of that actually came from our block grant, our substance use block grant. Next slide. This is one of the slides that we put in here to illustrate for you the blending and braiding of revenue sources. So just within this one contract for a behavioral health safety net, there's 8 different revenue sources, if I counted it up properly. You'll see in there that the beer and wine revenue, that's part of it at 16%. That is money that OHA gets from OLCC that we use to spend on SUD services and supports. Next slide. The next big area of spend is on the behavioral health resource networks. So again, as a bit of a 101, with Measure 110 funds, that's coming from marijuana revenue, and it's set aside in a drug treatment and recovery services fund. The money is actually overseen and directed by the Consumer Oversight and Accountability Council, and the grants are administered by OHA. That's important to note because when we're talking about different pots of money and rules and oversight and administration, this is one where, although OHA plays a role in grant administration, it's ultimately a consumer and community-led pot of money. By rule, the funds must be used for screening and referral to services, comprehensive behavioral health needs assessments, peer-delivered outreach, support, mentoring, and recovery services, harm reduction services, and low-barrier SUD treatment and services. Next slide. In terms of the breakout of the funding, so this breakout is based on actual provider expenditure reports. This is the data that is actually really good, and we're very proud of the data coming in there. You'll see that peer support is the highest segment, with housing services just behind. The takeaway from this slide really, and from the behavioral health division spending generally, is that a lot of this funding is funding the other areas of the care continuum other than treatment, where there are gaps, where we don't get to see things from billable services. And Measure 110 funding has been very critical for that. Next slide. And in the final bucket, it's a collection of direct contracts and grants. Most of the money in this section is coming from our 2 big federal pots of money. So the first is the substance use block grant, and the other is through our state opioid response grant. In terms, just a little bit in terms of what these sources are all about, they're both awarded every 2 years. The SEPTRS block grant generally is pretty flexible. States have a lot of lateral in what they can do with their money. Importantly, the funding amount we get from the federal government is based on population and not need. You can see how that can become problematic if the state is experiencing population declines, for example, or if need is out of whack. The funds are supposed to be used to supplement but not supplant state dollars. There's pretty flexible use. Like I mentioned, there are some parameters. 20% is on prevention, so that goes to our public health division, 5% for pregnant parenting persons, and no more than 5% on the admin activities. And it can really cover a wide range of services, including recovery programs. We have a recovery high school known as Harmony Academy that's supported out of this grant. There's been some workforce development, including scholarships and training for CDICs, for example. And you happen to be the block grant guru. Did you want to add anything else about
No,
Scepters?
just that the block grant is really designed to fill service gaps, right? So once providers receives block grant funding, they're not calcified there forever, right? It's really supposed to be ever changing as you're developing your system of care and you're like, oh, there's a gap where no other funding will pay for it. SAMHSA now has quite the auditing process that they request to drill down the results at the person level. So that is relatively new. And so I think that previously there was a little bit more bandwidth where block grants could fill in. And now it's much more specific to like, how is this a service delivery? It can be like an increase in staff, right? Saying that this will increase the number of individuals served within a program. So that can happen, but it is much more specific. And I think the Harmony Academy actually started with the SOR grant. So that was part of it. But the block grant is getting much more stringent than it has been in the past, and requiring much more reporting. Yeah.
On the other side, we have the state opioid response grant, again, awarded every 2 years. The grant priorities can change cycle to cycle, but they're a little bit more limited focus in terms of the populations we're looking at. So it's folks who are at high risk of opioid use disorder and stimulant use disorder. And the funding has been used, again, for a range of things, including harm reduction, overdose prevention. It's been used to help expand medicated assisted treatment. I believe the harm reduction clearinghouse, the naloxone supplies are funded in part by the SOR as well as some critical funding for peers. Okay, next slide. So we did want to point out a few of the other notable investments, especially that came out of the 21-23 biennium, which can't be carved down into SUD spending. And this is one of the big challenges with a report like this, because especially with the high incidence of co-occurring disorder, what counts as SUD or mental health can be very, very tricky. So just a couple call outs here through HB 52 and 5202 and HB 5024. There was about $230 million allocated through those two bills for behavioral health residential treatment and housing. It was directed towards folks with serious mental illness, but again, because of that high incidence of co-occurring disorder, you expect to see those funds reach folks who are struggling with substance use. In terms of the expenditures, 100 million coming out of HB 5202 was expended, all 100 million. And about half of that funding was given to organizations that had at least one mention of substance use disorder or co-occurring disorder in their grant applications. So about half of that funding is going to organizations that are very explicitly interested in serving those populations. The other 130 million coming out of 5024, there were no expenditures by the end of that biennium. That money is still rolling out. On the workforce side, we had 3 different bills, cumulatively putting in $213 million into the behavioral health workforce. HB 2949 and HB 4079 directed some of our American Rescue Plan Act funds specifically for supporting clinical supervision and workforce development. By the end of fiscal year 2023, 13 million of that money had went out the door. And then HB 4004 allocated $133 million in general fund for direct distribution to providers and organizations so that they could increase wages and pay bonuses, for example. Next slide. Another workforce investment area that was not included in the analysis in the summary tables because it is not SUD specific were some investments coming out of our health policy and analytics division, specifically $1.9 million for the healthcare provider incentive program. This goes to a range of behavioral health professionals, including SUD professionals. And then another call out here, which isn't a state source of money, is loan repayment that folks can get through the federal government through the National Health Service Corps. That's another important part of the workforce piece, is that money that folks can get through loan forgiveness. Okay, next slide. On our public health division side, there's really three main pots of money. The first is the alcohol and drug prevention and education program. This is where a lot of our the 20% prevention fund set aside from the SEPTRS grant is coming into play. This does support state programs. That's not included in this total. The state infrastructure isn't included in this total. This reflects the money that is going out to counties for alcohol and drug prevention and education. And it's supporting implementation of the SAMHSA Center for Substance Abuse Prevention 6 strategies. So that's information dissemination, problem identification and referral, community-based practices, prevention education, alternative social settings, and environmental and policy strategies. Next slide. A smaller amount of money from a CDC grant is going towards overdose prevention and education. This is primarily looking at overdose mortality and morbidity surveillance and other data projects. And then the largest share of their funding is going towards the tobacco prevention and education program. And really the vast majority of the funds they get for that are coming from tobacco taxes through ballot measure 108 and 44. Another much smaller budget item here is the prescription drug monitoring database. This is a database where folks who prescribe controlled substances enter in those prescriptions, so monitoring use of controlled substances can be done. Next slide. So this is another slide where there's a few things going on here and takeaways. One, that big blue pie piece there. That's the tobacco funding coming from tobacco taxes for tobacco prevention and education. And so immediately on this page, you're seeing in the public health division prevention budget, they're getting vastly more dollars on tobacco than they are for alcohol and other drugs. Everything but the khaki slice at 3.5% represents, almost all of those represent their alcohol and other drug funding sources. And it's just another way of illustrating just how complicated their budgets are and what they have to really scrap together to make a prevention funding budget. Okay, that's it for the spending data. Do we want to pause and take questions? We can move on to cost estimates.
Not seeing, oh.
I have a
Under
question.
name?
Yeah, sorry. Then I get that right.
Yeah,
when it says
eventually, yes.
Craig Prinz, OLCC. Samantha, can you go back to slide 16? I want to make sure I understand. So you see the general fund 10%. OLCC makes alcohol revenues available to the general fund, 350 million about in 21-23, and it's mostly liquor sales. That could be, I mean, that money that we make available to the general fund, there's no way to see that, correct? It would be in that general fund investment if we said, well, let's say that general fund investment, which the legislature makes, is based upon those funds. Is that right?
That's right. The general fund is going to be a pool of money from a bunch of different sources, so we wouldn't be able to tell.
And then so the beer and wine there, I assume, would be the 50% of beer and wine that goes into I want to use the right word, the mental health account, the OHA account. It wouldn't be it would be through that earmarked account for mental health and addiction.
That's correct.
Okay. I just want to make sure, because when we present, we're going to be presenting about revenues made available to the cities, counties, and general fund. And this is, so it's really, that's looking at what funds are made available. This is funds actually spent. I just want to make sure for my head and for those when we present kind of what's coming in versus what's going out. Thank you.
Janelle Romaine, Oregon Beer and Wine Distributors Association. I was going to say something similar about the first slide that showed alcohol at, I think, 13 million, and a big general fund amount that, while we've always argued that more should go to some of these programs, that there is money from the general fund there that, when you're looking at all those funds, it's not necessarily that only the alcohol money is in the alcohol fund.
Mhm, mhm.
Yeah, I think a way of looking at it is, these are set asides, right? So the beer and wine, this is a set aside for OHA. And on that slide where we had the federal and state funding sources, those are set asides from those revenue buckets going to state agencies. So you're absolutely right that there's other things that factor into the general fund that we can't parse out here.
And then also just the details that we can share if interested
Yeah.
around like where the alcohol funds go directly to city and counties, right? Because this is where the state gets funding to then
Right.
pass through. So that's the other detail where I think then you'll be like, oh, okay, that makes sense how it all adds up, but not necessarily parsing out the general funds, but that's just a portion of that money.
That's right. And just for a couple of figures out here, you'll see this if you see the supplemental tables, but the direct distributions for the alcohol revenue going out to cities and counties is about 174 million over the 21-23 biennium. So that's showing you that those revenue sources, it's leaning towards direct distribution to counties versus going to a state agency and then getting distributed out, if that makes sense.
I have a follow-up question. Just, you had me clear in my head now. So,
And then it messed up.
so when you just said that for the counties, 10% of the alcohol distribution statutorily goes to the counties. And we're the second largest source of fund for counties. Are you referring to that, or are you referring to additional funding from another?
It would be what is that statutorily mandated direct distributions, never passes through a state agency. That would be the 174 million, according to the data that I believe OLCC actually provided
Okay.
to us. So,
All right. I'm getting nods. So yes, I think I'm tracking. Yeah, so that's that statutory, the statutory 10% to counties and then the 34% to cities. There's two different frameworks. You're talking about that money, and that is unrestricted. Then the city and county get to decide
Right.
what they will do with that. Thank you.
Okay, I'm not seeing any little hands up online. Carry on, folks.
all right. So we'll dive into the cost estimates to address unmet need, possibly the findings making the most splash in this study. We're going to go in a bit of a different order from the report. We're saving workforce for last. I know there was some discussion at the original preliminary findings meeting, so we'll save that one for last. Starting with school-based primary prevention, this is work that the consultant did with the Oregon Department of Education to look at what is the starting point for understanding need in schools right now. What they looked at was developing out on both the state and on the educational service district side. So this can be one school district or it can encompass a couple different counties or a few counties, what staff and infrastructure are needed to broadly implement culturally relevant strategy and programming and developing program and practice tools to support all of that. A second piece of this is looking at the supplemental curricula that was required out of SB 238, specifically focusing on opioids. And the third part is more staff support and contracting for implementing tribal and shared history. This piece of it is, as ODE describes it, is really, it's a social studies curriculum that's culturally relevant and it's seen as a protective factor. If you're getting culturally appropriate social studies education, then you are just generally doing better. So within this $5.6 million, this is an annual, reflecting annual costs. Most of it is going out to FTE in each of the educational service districts to support the school-based primary prevention programs. Next slide. On the community-based primary prevention side, the consultant worked with our public health division colleagues to look at what funding would be needed for a comprehensive polysubstance use prevention program. What their starting point was looking at Oregon's tobacco prevention and education program, which in 2022 met the CDC's standards for what would be considered a fully funded prevention program. And what they ended up doing was taking that amount of funding that they got, which is considered fully funded, and relating it back to the economic burden of tobacco to see what percent of that budget yields, what percent of the harms is yielding what budget. So it'll make more sense on the next slide, I promise. Okay, next slide, please. Okay, there we go. So the looking at the economic harms and burdens of various substances. So the top data that you're seeing there is based on the Alcohol and Drug Policy Commission strategic plan, pulling in data from a study called Shoveling Up, where it was trying to untangle the economic and social harms of various substances. You'll see $2.14 billion attributed to tobacco, 4 billion to alcohol, 500 million to other drugs, and then 5.9 billion to harms not particularly linked to a particular drug. It's an important piece of the pie because the 500 million, for example, that you're seeing for other drugs, it might be much higher, but we just can't untangle it from, polysubstance use. So what they ended up looking at was relative to those harms in tobacco, what is the percent of our fully funded tobacco budget looking like? It's looking about 3.7% if you do it that way. And they applied it to their biennial budget for alcohol and other drugs to come up with these target amounts. So this would be if we funded alcohol prevention and other drug prevention the same way we did tobacco, it would be $148 million for alcohol and $18.5 million per biennium. In the report, you'll see an annual figure, so it'll be half that.
I'm sorry, you said a per biennium? That's, and you said 18.5, I saw that differently as
For other drugs.
other drugs, it's other drugs, and that also says before 2020.
I believe the before 2020 references they used the budget data from before 2020, and I can follow up with Tatiana about the rationale for doing that.
Cheers.
If you want to
Oh, you're still here. Okay.
Okay. It's also because that's pre-fentanyl. So that is the data that we had prior to the latest opioid impacts of fentanyl. And so, again, probably more conservative because we're just now really being able to understand what both the economic, social, and funding impacts of fentanyl. So we're deep into that epidemic right now.
I'm Danelle Romaine with the Oregon Beer and Wine Distributors. On the slide before this, it looked like, and sort of what we've heard generally is that prevention is relatively inexpensive compared to treatment, and as money kind of goes through the process. Looks like the legislature funded the opioid program for, what was it, $175,000? Is that what it said in schools? Is that right? In the slide before this?
One more. There we go.
Yeah. Supplemental curricula for opioids. Is that right? Am I reading that right? $175,000.
So those are the cost estimates for having staff to implement those curricula. So the original bill, SB 238, I believe shared did not come with funding, and they did share though that out of this last session in HB 5204, they did get some funding there. So I think those numbers, because the report timing came before that officially passed, it's still in there.
So is that 175,000 funding an opioid curricula in public schools now?
So there's two components. Now, my understanding is that funding was just passed for state staff, I believe, and I'll have to check with OD on this one. So that amount might be lower on the state staff side for the opioid curriculum specifically. But the figure you're seeing here, that would be looking at FTE at the state level to coordinate those curricula.
Okay. And so in theory, another substance could be added to that for a similar amount. Is that right? For 175,000, could you add alcohol to that?
You could. I think the way ODE is probably approaching it, though, is more upstream. So when they're working with children, families, and family members, they're looking at more root causes. And so even though SB 238 was specific to opioids and overdose among youth and young adults, they are also working to make sure it aligns with our state health education curricula standards. And so this work will move out in the fall and be available to all teachers across the state to use along with any of the other resources that are part of their standard curricula kind of tools in their toolbox. And so, yes, I mean, any funding that would come, I'm sure they would add it as part of a more comprehensive substance use prevention approach, which would conclude overdose, but other issues as well.
Okay, thank you.
Tom Jean, OHA. Could we go back to the slide we were just on, 28? I just wanted to highlight and clarify there. So the 10 million under the blue alcohol box is kind of what the current level of funding is. And I mean, in this piece, and then the 148 is applying the results of this study along with the kind of the same formula from CDC would get us to $148 million for alcohol. To really, that's how much we should invest to address alcohol harms based on the same amount. And that amount is 3.7% of the total burden. Is that correct?
That's right. That's the methodology we use for tobacco, right? And so we know we have a fully funded comprehensive tobacco program for 25 years now. We've seen what the outcomes are in terms of reducing consumption. And so that was the rationale, is like, what would that look like if we had a similar fully funded alcohol program and overdose prevention program? Could we get to those same outcomes over time? It's important to note these numbers. PhD provided what we call the fully loaded costs. So we have state interventions that are also evidence-based prevention interventions. So for example, the tobacco quit line is an example of that. We administer that, and so it's part of the system of investments. So those numbers will look a little bit different because they're the full, every single penny that we spent on any part of the prevention system last biennium, including the state infrastructure.
Thanks. So the bottom line is we're at about 7% of kind of the recommended need in terms of alcohol funding. The 10 million out of 148, it's about 7%.
Well, and the other part of the story is just the inequities within the funding package, right, compared to tobacco.
Thanks.
Just Aaron Sarnoff, Two-Town Cider, a point of clarification. The tobacco funding core is on cessation, correct? Not moderation?
It's primary prevention of tobacco. So it's trying to prevent particularly youth, but anyone across the age span from starting in the first place. And then a part of that is cessation. So if we're not successful in preventing use, then some of that funding goes to helping people to quit.
Prevention, though, more than responsible consumption. For tobacco, you're trying to stop tobacco use.
That's right. That's right.
Okay.
But it is a legal substance like alcohol. And so it is sometimes more challenging to tell that story compared to some of the illicit drugs that we also work with as part of an overall approach. I think that's an example of harm reduction too, you had shared earlier. So even within tobacco, anything we can do to help someone use less tobacco, even if they never quit in the end, is still a win for public health, as well as for them as individuals and families as well.
Senator Solomon, please.
Thank you, Madam Chair. A couple questions. One was, so a lot of the money that came from the tobacco program came from the tobacco settlement. Is that correct?
We, when that settlement happened a number of years ago, none of it came back to prevention. So all of the funding you see there came through ballot measure 44, and then most recently ballot measure 108. And then we have a little bit that is the CDC grant.
Okay, thank you. My follow-up, Chair?
Yes.
Thank you. Did you have a program in mind that this is what the program is going to look like and when you did the tobacco one, or did you have the money and then build the program? My concern, I'll give you the little bit of when we looked at the slides to see how much money has been coming into the counties, I'm not here to say that we don't have an issue with addiction in Oregon. That is an absolute, everyone knows it. But my concern is that do we build a system that has real measurable results to make sure that we're affecting change and there's accountability? Because sometimes just putting the money to it, without that, how do we know it's working? And so my concern is just having the money and then building the system, or is this system in place?
Yeah, I think those are all excellent questions. And so the slide before, I think Sam, you showed talked about a comprehensive approach. And so you'll look at that CDC's way of telling the story of no one intervention in of itself can move the needle at the population level. And so it takes all of these combined. So some of those are county partners, some of them are tribal partners. Most recently, it's our culturally specific community organizations. 25 years ago, when Oregon started that $2.0 million, to your point, to move the needle on population health is a 20 to 25 year journey, right? And so that funding allowed the program to start creating that structure, and then over time being proactive about looking how to build that out. We don't have the slide that shows the reduction in consumption, but that's an example of a comprehensive approach. We have similar infrastructure for alcohol and overdose, but just not the same dosage, right? So Sarah, you can speak to this even better than me. I mean, we have alcohol prevention coordinators in theory in every state and tribe, but many of them are just not even half-time funded. So that's an example. In tobacco, we have at least sometimes 2 full FTE working in every county. So workforce is critical. And I think the hope is that whenever we can bring revenue, it builds towards the system. So we have long-term infrastructure in place like we've had with tobacco the last 20 years or so.
Can I ask you to go back to the graph slide, that one? Thank you very much. I do want to note, because I heard Erin's voice tilt a little bit when you said the word cessation, or essentially the assumption of stop. I don't think, well, let me just say, I did go to school I never actually did. I mean, I was working in treatment for a little while there, but I don't actually sit in the field right now, but I do have a certificate in alcohol and drug studies. And part of that, and then having dealt with community and friends and family in the works for many, many years, what we know is that, well, there is never going to be an intention to eliminate alcohol. That's not going to happen. It's not going to happen. We may want to do it for cigarettes, but it is not going to happen for alcohol. Not only because it is deeply embedded in culture, deeply embedded in economy. It's just forever. So that's not the issue. The issue, though, is the cessation for folks who struggle with addiction. And I think that's the piece that maybe is not as clarified here as we should like to see it, maybe. And I guess I'm asking that question. Is that specific to the piece of the impacts, the harmful impacts? Is that exactly what we're seeing there? The harmful impacts being mitigated by that much resource being invested in it. Is that what we are seeing here? Because I want to be clear about that so that we don't, because I heard it in the tone of your voice, Erin. So we're simply talking about the mitigation of harm done by that addiction issue.
Well, I remember just like the reason we had the ODE slide up before, right? We know that for alcohol in particular, as well as with cannabis, that for the most part, our major concern is with children, youth, and young adults, right? Their brains are still developing, their bodies are growing. So that's where when we work upstream, we're primarily working with children and families and youth. We know we also have issues across the lifespan, but that's where the bulk of our commitment goes to building those programs, policies, and environments that help youth never if they are going to use to wait till they're later, to delay use, and then to get support if they do need more support as they use.
And I think, Chair, what you're speaking to, we've spent many, many years and still are, we're in our residential treatment programs for substance use disorder, it's tobacco free, right? In terms of like linking, complete stop of tobacco use, improved recovery outcomes. When you're working in the field and you're taking someone to withdrawal management, they're like, I'm going to walk if I can't have a cigarette. You're probably going to find them a cigarette. That's just,
Yeah.
I mean, that's on the ground how it works. So there are reasons to have a cessation approach as it relates to the substance use disorder service work. But there's also the harm reduction approach where it's like, okay, I think we can find you a cigarette so you stay and get full withdrawal and enter treatment and start that there. So
Yeah.
it's I think it's evolving, but it's definitely even for adults in seeking recovery, a critical conversation.
Yes, I had the joy of working in treatment at that moment in time when they stopped us from actually allowing people to have cigarettes in treatment. That was horrific. By the way.
Well, one of those CSAP strategies is problem identification referral. So that is the magic of early intervention and primary prevention is knowing families, communities, being able to get people early linked into services. So there's prevention can still happen, but a little bit later if they're starting to see problems around alcohol use.
Right. Okay. Any other questions, comments about this piece? Carry on. Did you did
One more question. Aaron Sarnoff, Two Towns. As when we saw the other societal costs, the majority of them were non-measured costs. They were usually in things like estimated lost productivity and things like that. I'm assuming that's similar in these figures that we're looking at here.
This was based on the Shoveling Up study, and so I am not the research analyst that's an expert in that data. Will Burchard, who is co-placed with the Alcohol Policy Commission and Public Health, helped to develop that methodology and work that through with staff. So that would be something that we could absolutely come back with more information.
I'd appreciate that.
Yeah,
Thank
if
you.
you're interested.
Thank you. Carry on.
Next slide.
All right, I'm gonna head back. Tag team today.
Moving into full service harm reduction programs. So how the consultant looked at the gaps, they examined the gaps in harm reduction programs in the 2022 OHSU PSU SUD gap analysis. And basically reviewing the data, decided that syringe exchange programs are sort of the core of harm reduction, even though some of the gaps we're seeing in that first table might be higher. For example, naloxone distribution that can be done in a variety of different settings. So they used as their baseline gap the syringe exchange program. They did update the supply side level based on 2024 data. So next slide, please. To calculate the cost of adding 56 programs in Oregon full service harm reduction programs, they looked at work that had already been done by the Public Library of Science in their estimated cost of comprehensive syringe service program in the United States. This is a methodology where you can look at both mobile locations and fixed locations, and it does break down by a variety of different cost components, including personnel and operational costs. So what you're seeing here is a per program minimum and maximum, and for all 56 programs, minimum and maximum. The max and min are influenced by the program location and also the size of the program. So the goal here was really to give a range of, smaller programs in different parts of the states. Here's what it would cost. And it's an area where, as funding is passed and we learn more about local needs, this can be used as a bit of a blueprint. So for the report, the consultant used the average across all of these. The average amount to install 56 full service harm reduction programs comes in at just under $90 million. Next slide. Opioid treatment programs, the consultant worked with subject matter experts in the behavioral health division to look at, again, varying types of programs, including mobile medication units, non-mobile medication units, which can be considered a satellite office of a full service program, and then the full service unit, which really has all of the services provided in one place. The takeaway here in doing this breakout by those different types of units really is thinking about geographic spread. Because someone is coming in having to take methadone and it's this place that they have to go to, it can't be done in any outpatient setting. You really want to look at geographic coverage across the whole state. Now, what type of program you choose to put in there can vary. And I believe some of this was based on understanding of local needs in counties. Next slide. In terms of the cost, they also looked at a maximum and a minimum. The maximum and minimum is really driven by the size of the program. So for example, for a mobile medication unit, the minimum of 150,000 might assume that someone has, you know, an airport style van that they're using, and the 350,000, you might think about a big RV serving as a mobile medication unit. They looked at the average total for this as well. For all 52 programs, $18.1 million. And these are startup costs, one-time startup costs. Next slide. On the SUD facility side, all of this data was originally derived from CAST, Calculating for an Adequate System Tool Estimates. That's a tool that was originally developed by SAMHSA to look at capacity and need within states. They looked at outpatient facilities, residential treatment facilities, withdrawal management, recovery residences, and recovery community centers. Two of those categories, residential facilities and withdrawal management, were the gaps were updated based on more recent supply side data that we got through another study that's happening in parallel. Just happens to be the same group that's researching PCG, that's looking at bed capacity across the state. Next slide. So for the costs for these SUD facilities, they honed in really just on capital construction costs. And one really important thing to note is that land acquisition is not a part of any of these estimates. It's purely how much to construct new facilities. Another caveat to that is that we might not need all new facilities. Perhaps places could be renovated, expanded. And another caveat is that, you know, some of the new developments that we're seeing can be multiple types of programs in one campus. So these might be on the high side in terms of the estimates, because it's really assuming brand new standalone facilities. They looked at a program called RS Means to determine capital construction costs. They had some assumptions you'll see there on that second column about the size of the facility in terms of the beds, stories, and square footage. And then they had a cost range based on location. Interestingly, the location cost ranges didn't vary quite as much as you would expect between rural and urban. And then they took the statewide average to do the total costs. So for new construction, capital construction costs of all those SUD facilities, $1.657 billion. Next slide. Okay, so getting to the SUD workforce. This has been, I would say, definitely the area of the report where we've been hearing the most from partners, lots of questions coming out around how the cost estimates were done, what was included, et cetera. The consultant took a two-pronged approach to looking at the cost estimates. First, they wanted to see how much would it cost to educate, train, and certify and supervise all new needed SUD workers into the system? And then what would be the cost of employing all of those workers once they're in our system? Next slide. So the gap data, the need data is based on, again, the 2022 OHSU, PSU, SPH, SUD gap analysis. That analysis looked at certified workforce primarily, including certified prevention specialists, certified alcohol and drug counselors, certified recovery mentors who are peers, qualified mental health associates, and qualified mental health professionals. They also looked at buprenorphine prescribers. We'll look at that on the next slide, but just a quick note that these are, again, based on the CAST methodology out of SAMHSA, and that methodology we confirmed did not examine other types of workers such as registered nurses. And that's important to note because registered nurses are required to work in some settings.
I would also add that the gap on the QMHPs is also impacting the build out of the crisis system, the mobile crisis system with the QMHP needs. So it's a double, it's impacting us in two different areas, is that one.
Next slide, please. So a note on the buprenorphine prescriber gaps. The OHSU PSU gap analysis did have a CAST estimate for buprenorphine prescribers. So those are your medicated assisted treatment prescribers. When that research was done, it was back when there was a waiver was needed to prescribe buprenorphine. That has since been eliminated. And so in order to try to figure out what the current supply was and potentially even if some of the gaps in access to MAT were still present, we ended up looking at the prescription drug monitoring database for unique prescribers of buprenorphine. So when they factored in that new supply side of the equation, what you'll see here is it's broken up by region. This is NISTA region, National Survey on Drug Use and Health. It's a SAMHSA survey. Region 1 is Portland area. There is an apparent oversupply of 47 prescribers, but still gaps across other regions and across the entire state, about 1,100. So it's tricky to interpret this data because one of the things we know is that there are a lot of barriers to MAT prescribing. There's stigma among prescribers and various other things. And so I don't know that anyone would dispute that there is a prescriber gap in Oregon. What that is exactly can be hard to determine, but we know for sure that there are things we can do that are not just bringing more people into the system to get medicated assisted treatment available. So that is, for that reason, they decided not to cost out that portion of the workforce.
And I think what you see is more telehealth now in our rural and remote areas that's coming out of like Harbor Clinic at OHSU and other facilities that are really comfortable prescribing. And it doesn't, there's been echoes, it doesn't encourage prescribers to prescribe, but it does meet some of the needs of the community members that are seeking services.
Next slide. So to calculate the costs of building the pipeline, that's education, training, supervision, and certification. They did look at existing administrative rule to see what kind of requirements there were around education, training, and supervision. And they also looked at the details through our certification agency, MACBO, to see what those requirements were. For the education side of it, they only included post-secondary education costs. So that would, for that reason, certified prevention specialists and certified recovery mentors, because there's no post-secondary requirement as part of the certification, that was not included. The big takeaway from this slide is that the education side of it, the post-secondary education, that's driving most of the cost. It's 1.7 billion out of about 1.8 billion is going to be derived from those education costs, with much less associated with training, supervision, and certification. Next slide. All right. So looking at the total cost of employment, they looked at a few different things. The first was they looked across several different sources at wages for these various workers. They applied a standard percent for benefits and fringe, and they looked at costs associated with administration and program support. So those are all the people that support you as one of those categories of workers. And then they added it all together. The total here came out to be about $3.2 billion for all those new workers to come into the system. And if you go to the next slide, we do want to untangle a little bit about the wage data here. So they looked at several different sources for wages, Glassdoor being one of them, a survey from the Oregon Council for Behavioral Health on what were considered good enough wages for the categories of workers in the study, And then they looked at a wage survey from MacBo from 2021 and adjusted it up for inflation 17%. So what I think the takeaway on this slide is that their wages that they used for this report, it's primarily they used the MacBo adjusted for inflation. They match pretty well and they track pretty well to the OCBH good enough wage, and in most cases, the Glassdoor median annual wage. And then with two exceptions, with the certified prevention specialists and the QMHPs coming in much higher. I think what that tells me is that with that inflation adjustment, we might not be seeing current wages being adjusted for inflation to really where we need to see it. And if MacBo does do a more recent survey, it'll be immediately obvious if wages have not kept up with that 17%. Next slide. All right, so here's the total bill. $6.85 billion. This, again, it's going to be based on how they did the cost estimates. Some of these are annual costs, so primary prevention on both the school and community-based side. Remember that those are budgets, by annual or biannual budgets, and employing needed workers also reflects an annual cost. All of the construction costs are considered one time, and harm reduction actually had a bit of a hybrid looking at personnel costs and startup costs. So next slide. I think one of the burning questions out of this is what would be the public cost burden for all of these costs to the system? It's very difficult with the underlying data to try to parse out how much of those gaps can be attributed to folks who are publicly insured or who are otherwise receiving services from publicly funded programs. So there's two ways to look at this. One is that, I mean, really, when we think about what are the public resources needed, some of it comes down to policy choices and what you want to invest in. So based on recent investments out of the legislature, there has been investment in education, training, and certification and supervision. We've had rate increases and directed payments in Medicaid. We've had funding for capital construction for facility expansion, and there has been some prevention funding just passed, a little bit of that OD money that I mentioned, and I believe the Opioid Settlement Board did just pass about 13.7 million for prevention one-time funding. The other way of looking at it too is to take what we know about the public cost share of behavioral health and apply it in some fashion. So the best data point we have at the moment comes out of the Healthcare Cost Growth Target Committee. They look at behavioral health spending across the state, looking at insurance by market, and also they include anything that comes out of a state contract. So for example, the service elements going to the counties. And what you can see here on this slide is that the only non-public source is that blue chunk, that commercial. So about 75% of the known expenditures on behavioral health broadly, this was in 1 year, was coming from public sources. Keep in mind that Medicaid, you'll see that that is the largest chunk there that does have that high federal match. So this isn't necessarily indicative of the state cost, but it is the public cost. Right. Next slide. Okay, so the big question, how do we pay for it all? The two ways that they looked at this was around maximizing the existing sources that are being used towards substance use disorder services and supports, and then looking at what additional dollars can we bring in. When we're thinking about maximizing existing revenue, really it comes down to using our money wisely and strategically and equitably and effectively. So some of the key points around this, really taking a cross-agency approach, looking at the pots of money and the funding collectively and not just agency by agency. Thinking about it in terms of equitable distribution, making sure we're including community and voices of lived experience in behavioral health financing strategy. We need to make sure that the resources are going to the folks who experience the greatest inequities. And they do mention in the report about the youth system and how underfunded the youth system is. This goes back to prevention. You'll hear our child and family behavioral health colleagues talk a lot about youth health, and serving youth is prevention. So that's a key piece of it. And then some supports for culturally specific providers and grantees. So when we're giving out the money, making sure we're using equitable funding practices, that we're looking at administrative burden and spreading awareness of opportunities. So those dollars are reaching those communities that have the greatest inequities. In terms of effectiveness, this comes back really across all three, is standardizing and tracking the data and outcomes, and standardizing it not only within agencies, but across agencies. Another piece of it that is necessary to track data and outcomes is to make sure we have adequate funding for research and evaluation. And that includes both on the agency side to do that research and also in organizations, because they have their own reporting requirements. And thinking about efficient use of dollars, this is where interagency collaboration comes into play. How can we align our funding and funding strategies? How can we pool resources? Potentially, we might consider what is the impact of blending and braiding all these resources. To the extent that those pots of money each have their own parameters and reporting requirements, how is that impacting the efficiency of those dollars? And the final piece here is looking at reducing the administrative burden on grantees. We want to track, we want all the data and outcomes, and we also have to remember that at the end of the day, that is a reporting burden for our grantees. Next slide. Okay, so in terms of new revenue sources, I think really there's just no easy answers. You know, when you're talking about over $6 billion of investment, there's not a lot of couch cushions that you can look under to fill those gaps, but there are things that we can do. Coming back to some of the threads earlier in this conversation, that federal Medicaid match is the single largest revenue source in this state. And so everything that can get done to leverage that match, the better. We can also continue to look for federal grant opportunities. We've already pursued the two big ones, which is the SOR and the SEPTRS grant. Certainly more come along, but there are varying dollar amounts and they're not necessarily consistent or sustainable. On the private side, looking at public-private collaboration, again, to the extent that even if there's any philanthropic efforts, you can look at aligning strategies there. Out of that data from the Healthcare Cost Growth Target Commission, there also came this question of, 75% of the dollars are coming from public sources. Does that say anything about coverage parity in terms of what private or commercial insurance is covering versus public insurance? Probably a lot of that is accounted for through folks simply just more people who are publicly insured living with substance use disorders and potentially higher acuity, but that is a potential question. Finally, on the state side, there's really two options. We can direct more of the revenues to substance use disorder, and that's one way to go about it, or we have to generate new revenue. The final piece of this, though, is coming back to those upstream investments and looking at social spending. And we can change the course of how we invest in the SUD care continuum by going further and further upstream. So thinking strategically, not just within an agency budget, but within a state budget, how much are we really doing towards housing and social spending and safety net in that way versus pouring money into the behavioral health system. Final slide. So we wanted to leave off with just a few key takeaways from the OHA point of view from the study. First, I think what is remarkable is that it is a first ever look at spending across the care continuum. And you saw those numbers. Prevention, such a small component of it. It directs our attention to what's getting invested in the system and where, and if we choose to undertake this exercise again on SUD spending, we can see how that might change over time. As Sam Byers mentioned in the beginning, behavioral health financing is incredibly complex. And frankly, the way that we finance care in a state contributes to our system fragmentation. Additional funding is obviously necessary, but it's not sufficient. When we go back to the medicated assisted treatment situation, for example, there's a lot that can be done through policy and program changes and awareness to increase access to MAT than just adding more folks to the system. And one thing that we really enjoyed out of this study was getting really foundational information on the costs. How much does it cost to build a place? How much does a mobile unit versus a non-mobile unit cost? This is helpful when we're looking, big picture where we want to move the funds, and we can get estimates based on how many of these things do we want to fund, and it helps with agency budgets as well. On our side, some of the key next steps, I think, coming out of this, we realized that there is a lot of additional research that could be done on workforce specifically to look at those gaps and untangle those more, and think about how we can integrate these with our workforce strategy. And there is a project being revived in the public health division to do partner mapping. And this is leveraging the data that was collected for this study to see at the organizational level where the dollar's going. So we can figure out how much someone is getting, but really the array of folks that are being funded through public dollars. And with that, we made it with 5 minutes to spare.
Not really. Aaron, go ahead.
Aaron with Two Towns Cider. A couple of comments and a question. That figure certainly raises some eyebrows. That's a big number. If we were to actually fund substance use recovery services to that degree, I believe that would make us 8 or 9 times higher than the highest funded state in the nation per capita. That's a lot. I also, in my previous presentation, have some pretty serious concerns with the methodology used to come up with those estimates. The CAST methodology doesn't actually look at utilization rates of our current assets. It instead uses survey data and makes theoretical, possible needs. I'm not aware of the CAST method ever being used for an entire state's recovery asset infrastructure. My understanding that the CAST method was generally used on the community scale, not like it is here. So I guess my questions are we going to do some asset utilization research in conjunction with this, or so that we have some real world data from the ground to know that these, all this investment is actually necessary, or is this the model?
So I think the way you look at the CAST estimates and the cost estimates generally is it is a ballpark. And it's once you start looking at local community needs, you're going to want to bring in those more specific data sources. So it is a general target to work towards, but we can't look at it as a definitive answer, is what I would say.
Yeah, I would also say, I think, and this is just thinking about like strategy for adult behavioral health side, what's happening today, we cannot build our way out of in time, right? Like there are some things happening, like there are folks living on the street, there are folks not accessing services that are available, sometimes because of geography, sometimes just because of a poor experience in the system itself. And so I think that even as the build out, if we said, yes, we're going to put billions of dollars into every single building that's needed, and all of that is true, one of the things, at least looking at the study, is there are some things that are more affordable, like the mobile MAT, and we need to start thinking about services outside of buildings right now, because the buildings we need is somewhere to put people so they can stabilize through services. Without that, the recovery chances start dwindling. And I think that there is just a different strategy on how we serve people that needs to happen too.
So again, sorry to follow up.
Yeah.
Is there any research that's going at current utilization rates, or is that, I hear what you're saying. I'm just trying to understand, are there any actual metrics from real usage rates that we can compare to these estimates to make sure that, a $6.8 billion investment is the direction we want to go, and that the things that we think we're trying to build capacity for are what's actually limiting access to services?
I think the need estimates can always be refined. There is a utilization component of CAST, though, I should say that. It is based on national figures. That's what was used for the 2022 gap analysis, but you can plug in local utilization numbers if you have that data. Utilization is not as easy to come by as you would think it is, though. All payer, all claims is our main source of data for that. And you're talking about millions of rows of claims data that has to be synthesized. I wish it were easy. It can be done though. And if that is a direction that the legislature wants to go, is to continue to refine these estimates, it certainly can be done.
And I'm also happy to go back to our Medicaid team and our health policy analytics team to ask specifically about utilization.
Yeah, it was my
Yeah.
understanding that that was not included. At least that's the communication that we've gotten in this task force so far.
Oh, and this report, but yeah, and I will follow up just to see how we track, if at all.
Okay.
Yeah, happy
Thank
to
you.
do that.
Great. I'm gonna go, do you need
Go
to-
ahead, go ahead. I gotta go pick up a
Okay.
kid, but I'm fine. It's
Okay.
okay. Chat.
Thank you.
Thank you.
So Laura,
I just want to thank you for your presentation and, share that I know talking about Medicaid rate increase is a big ask sometimes, but I do want to share from an agency perspective that, we received an integrated co-occurring disorders grant from OHA, and it's been an amazing experience. We've gotten so much support through that grant. I have questions, I get immediate emails and calls back, and I have a team supporting us. And we have increased staff to be a co-occurring specialist. So basically having degrees in SUD and mental health, right? Having both backgrounds, from 30% to 80% of our staff. And it wasn't that huge of a capital investment, but just having that support has been a game changer for our agency and our clients. So I'm really hopeful that maybe there can be more grants like that so that more agencies can benefit from that type of support.
thank
Thank
you.
you. I appreciate that statement just because we know the folks that we're serving are not a singular, it's not like, okay, they only have a substance use disorder or they only have a mental health diagnosis. The majority of folks are needing both. So the whole person health is really critical. And that was kind of our first step into that on the behavioral health side in a purposeful way. So thank you.
Thank you. Senator Solomon, please.
Thank you, Madam Chair. I thought we were kind of running out of time. I have a lot of concern about this. I appreciate the presentation, but I have far more questions than I do excitement about, wow, this is it. This is the plan. I'm concerned that, I'll follow up, but is this based on looking at another state and looking where there has been considerable amount of progress around prevention? Or is this an Oregon developed, like looking at research and saying, this is the plan that we should develop? And that's my first part of my question. Like I said, I have many, but my second one is thoughts on just taking this in incremental steps of looking at prevention in youth and moving forward, because the current right now it is overwhelming and it is horrifying and it's scary that we see people in addiction and suffering and dying. My concern is how do we address the prevention of youth when the big focus is going to be on additional money for the crisis?
So I'm gonna pause you from this. Because we can't answer that question, all of those questions right this very minute, right? Because we are out of time. But I do want to note also that this is a step in the process, right? Not the end all be all or all of the answers to all of the questions by any stretch of the imagination. I mean, I was literally rolling through my mind as you're talking about all of the costs and whatnot, and just like, we don't have that. We don't have it. We don't have it, and we're not likely to get it anytime soon. So we will be trying to figure out strategically how we walk through pull pieces that we need, figure out how we do some crosswalking of different things that are necessary in our moment in time. This is not a, I mean, I had no expectations that we would come up with the answer today. We haven't, right? That's not the answer. We have a lot of work to do to figure out where we go from here, looking at this analysis and others. I mean, there's a reality also of all of the MACBO data and the bodies in the room that are needed. There are a lot of bodies sitting who haven't been engaged for a long time. And something's wrong with the system for getting people engaged again. We have a mental health crisis. We have lots of things going on. So we're not finished. And I really, really want to encourage people to reach out and ask the questions about the data so that we can be really, really clear about what we're talking about going forward. Okay. And I don't want to tax you anymore, right? This very minute is a little after 3. People have other meetings, I'm sure, that they didn't get to. So at that, folks, we are adjourned.